Okay, so I've got a confirmation that we are live on the link. So I'm just waiting for 7:30 and then I'll start.
Yeah, sure.
Got the confirmation that we are live. Okay, thank you so much, Amrishi, for the thumbs up. Okay, so we are just about to start. Okay, Amrishi, we can start, right?
Yes.
Okay, thank you. So, very good evening to everybody that is listening to us. I welcome, on behalf of Curious Mankind Specialities, all the esteemed doctors and esteemed audience that is listening to us all across the country. I welcome our speaker, Dr. Munna Sherpa. Sir is an MD, senior consultant physician at Mani Rindu Medical Center in Darjeeling. So, sir, on behalf of Curious Mankind Specialities, we welcome you and thank you for your time and thank you for such an enlightening talk. When I talk about sir is a consultant diabetologist and an internal medicine specialist at Mani Rindu Medical Center in Darjeeling. When I talk about his experience, he's got a wide experience in the field of medicine and diabetology. He's also a visiting consultant at the D&D nursing home in Darjeeling. And he's also practicing at Adarsh Nursing Home at Kalimpong. Dr. Sherpa completed his MBBS from Calcutta Medical College, West Bengal, where he worked as a house surgeon in the Department of Medicine and senior house surgeon in the Department of Pediatrics for 1 year. Sir is also the ex-secretary and president of Indian Medical Association Darjeeling, founding president of SPASH, a voluntary organization dealing with spastic children. Sir, we are honored by your presence and thank you for taking out time and delivering the talk on such a fantastic molecule. Sir, over to you and thank you again. Thank you once again.
Thank you. Well, good evening, everybody. I hope I'm audible and is my slides visible?
So slides, I think you have to share. Slides are not visible.
Not visible. I had said, but I don't know. That's why. Just a moment. Let me just see. Is it visible now?
Yes, now it is visible. Yes.
I'll make it full screen now.
Sure.
Is it okay?
Yes, sir. Perfectly okay. Yes.
So I can go ahead now. Yeah. So good evening, everybody. Thanks for your time. Today, I'm going to talk about Dapagliflozin, the current perspectives and future outlook. I don't have to tell you much about the Dapagliflozin. It's a very, very popular molecule now, and which has, from the background to it has become a first-line therapy, not only for diabetes and also for the heart failure with or without the presence of diabetes. Such a tremendous impact it has made into the current armamentarium for your treatment of your diabetes and also the heart failure. So I'm going to just touch upon the important points and few of the trials. Most of you know about the trials, but I'll just quickly go through the slides. Okay, so there are around 50 slides, so I'll have to rush actually. So I start with the background, the overview of SGLT2 inhibitors. So there are unmet needs of Indian diabetic patients. Indian diabetic patients are very notorious for having an early stage onset for diabetes and then the premature death because of the heart, heart attack, and also they have got a very poor beta cell function right from the beginning. I mean, when you start to get the, like a diagnosis of the diabetes in Indian populations, majority of the beta cells in them are already defunct, okay? And also they have a very high rate of CV rate and complications. And then in such scenario, like we have to look for the medicine which has not only effect on the glucose lowering effect, but also we have to look at the other parameters, like say for instance, it has to have a sustained long-term, data, which now we have available for the Dapagliflozin. And also we know that it causes very less of hypoglycemia, and it has a great advantage in the working population. And there is a reduction in visceral fat. The visceral fat correlates directly with the cardiovascular like outcome in a patients with diabetes, especially patients with the diabetes. Maybe it's a phenotypically obese or the non-obese, so-called TOFI. I think we have discussed in a previous one of my talk that I talked about the TOFI. TOFI stands for thin on outside, fat inside. That means typical Indian phenotype. You have a normal body weight if you compare with the Western people. You have a normal body weight, and even the BMI. You might be having even a low BMI, still you are metabolically fat. That means you have a lot of intra-abdominal fat and then the visceral fat, which is very much detrimental to the cardiovascular health, as well as the in presence of diabetes, it becomes even more so. So SGLT2 inhibitor has shown there's a reduction in visceral fat, which very few other drug actually causes this one. And it has been found that like you don't have to look for the visceral fat. You can just do the abdominal circumference, and then that correlates very well with the, metabolic syndrome. Now, the biggest part of this medication is like it's insulin independent. It has an action which is insulin independent, whether you have or you don't have a insulin, the Dapagliflozin works. And they also reduce the not only reduce the glucose, they also reduce the weight, systolic BP approximately 5 millimeter, and then it has a neutral effect on the lipid profile. Although it reduces the fat, but it has a neutral effect on the lipid profile. Therefore, it helps us modify the risk factor as well. So this is to show the mechanism how this Dapagliflozin works. All of we know that there's a SGLT2 inhibitor, which is mostly concentrated on the proximal convoluted tubule of the nephron. And now, when you use the SGLT2 inhibitor, it blocks that SGLT2. There's many SGLTs like SGLT1, 2, in various 3, 4. Some of them are in the brain, but we are concentrating mostly on the SGLT2, which is located in the proximal convoluted tubule of the kidney, where when you block it, then there is a glycosuria. Okay, so this is the basic mechanism. So what happens, like once you block with the drugs like Dapagliflozin, once you block, then the sugar passes to the distal like a tubule, collecting tubule, and then the large amount of glucose, as much as 70 grams per day. Or in other words, if you multiply that by 4, it becomes 280 calories per day is filtered every day. This is to show the benefit of Dapagliflozin, okay, and then to show the unique mechanism of this medication. DAPA's inhibition of the SGLT2 results in daily urinary glucose excretion approximately 70 gram per day, providing significant HbA1c reduction. So it has a very good HbA1c reducing capability. And also it has an additional benefit of weight loss and a reduction in the blood pressure. All of we know that one. And another important thing I have already told you about, this works regardless of beta cell function. And also it complements the insulin dependent mechanisms, and also it has a very low propensity for the hypoglycemia. These are the big effect. And then this is to show the consistent reduction in the HbA1c around 24 weeks after the initiation with the comparable medication, I mean the comparable placebo. So as compared to the placebo, whether you use only with the placebo or the dapagliflozin alone, or whether you use add on to metformin or to the sulfonylurea or even with the insulin, all these, like a medication, when you combine with the dapagliflozin, it reduces glycohemoglobin significantly in all the cases, as compared to the, like it's a way beyond the comparator molecule, that's the placebo. And this is to show another effect of DAPA metformin combination. Okay, so this is to show the mean change in HbA1c percentage from the baseline. Again, at the end of the 24 weeks, if you look at this solid black line, this is much way below, I mean, the significant reduction in the HbA1c as compared with the placebo. So DAPA works in patients who are not controlled on sulfonylurea metformin. So if the patient is not controlled on these two drugs, if you add DAPA, it significantly reduces the HbA1c. And this is to show, like the dapagliflozin as a reduction in the HbA1c. Okay, this is again, it's a sustained over the time. It's not only that, sometimes what happens, sulfonylurea brings down the glycohemoglobin very effectively within 1 to 2 months, but after that, after some time, the effect of sulfonylurea starts waning down. Okay, so it starts slowly fading down, and then it comes back to the it jumps up to the baseline level. Whereas dapagliflozin, it not only reduces effectively in the beginning, and it keeps it sustained for a long time, as long as it has been studied up to 102 weeks. That's about 2 years. So it has a sustained effect on the glycohemoglobin as well. Just give me just a moment. Let me just pull it down. Yeah, now it looks okay. So this is to show the comparable HbA1c reduction to sulfonylurea at 52 weeks primary. So compared with the, glimepiride, if you see in terms of glycohemoglobin, it has a comparable effect. So it is not inferior in terms of reducing the glycohemoglobin, but with a lot of advantages. We are going to come to that in the subsequent slide. And as with the, once you compare with the glimepiride, when you talk of hypoglycemia, it's a very, very less compared to, you see this gray one is for the glimepiride, and then this brick red stands for the, like a dapagliflozin. It has a much less incidence of hypoglycemia as compared with the glimepiride. Again, this is to show the, weight loss. There's no question that this is one of the medication that has, shown consistently, over the time, it reduces the weight up to 4 to 5 kg. Whereas glimepiride, in fact, it either it's a weight neutral at the most, but mostly they gain the weight up to 1.36 kilograms. And this is a convenient once daily tablet. How do we prescribe? About 10 milligram once a day, that's the recommended dose. You can start with the 5 milligram if you have a problem with the a hepatic impairment, and it is well tolerated. The dose may be increased to 10 milligram even in the presence of mild hepatic impairment. And then time flexibility, any time of the day. And then, of course, it's regardless of meal, whether you take a meal, whether you are irregular on your meal, doesn't matter. But once you take it on 24 hours, it works very well. No known drug-to-drug interactions with other commonly prescribed type 2 diabetes treatments. And this is to show the safety profile of SGLT2 inhibitor. It is well established. It includes some of the mild adverse events, say for instance, genital infection. It's a class effect. It's almost all the SGLT2 inhibitor has the same thing because of the, a presence of excess sugar in the urine, which is the mechanism, actually the basic mechanism of action of this drug. So you expect to have some kind of a genitourinary infection. That is one of the reasons you have to tell your patients to drink plenty of water and then urinate. Don't hold your urine for a long time. That is also another important thing. And then keep your private parts very clean. And there is an increased risk of hypoglycemia when used in combination with sulfonylurea engine, obviously, because these two drugs, along with the dapagliflozin, can significantly reduce the blood glucose so much so they can go into hypo. So that's why you are supposed to monitor the insulin dose and sulfonylurea dose very closely. When an LCL2 inhibitor is used in combination with sulfonylurea and insulin, a lower dose of sulfonylurea insulin may be considered. That you have to do it according to patient's condition. And in rare cases, there are some side effects like diabetic ketoacidosis, although it's rare, but it has been described. And you have to follow the sick day rule. Whenever a patient is sick and if the patient is hospitalized, or if there's a chances the patient is undergoing the dehydration and patient needs a multiple IV fluid, it's better to switch over to insulin for the time being, and then you can again come back to the the SGLT inhibitor along with the other medications as per the recommendations. There was some concerns about the lower limb amputation, but that has been reported with the canagliflozin, which has not been reported with the dapagliflozin. And in rare cases, there's a fourneous gangrene has been associated with SGLT2 inhibitor. The basic principle is, moment you suspect, first thing is to do is you stop the drug, confirm the diagnosis, and then go accordingly. So these are the cautions and contraindications. We will not go into the details. This has all been given in the product insert that you get with the product. And another important aspect is the volume intake, and then eGFR should be monitored whenever initiating the patients on the SGLT2 inhibitor. So hydration is very important. If you properly hydrate the patient, most of the complications associated with drugs can be alleviated. So, and it also has some effect, like if you add with the patients who are taking the diuretic, then that can cause, dehydration. That's why you have to ask the patient to take a lot of water. And it has also blood pressure lowering effect, although which is not the direct effect of the diuretic effect of the SGLT2 inhibitor. And then there is special attention should be given to the volume intake we have talked about. And then there is a initial fall in SGLT2 eGFR. When the drug was introduced in 2015 in India, one of the big concern was because many patients, many clinicians reported there was a mild reduction of the eGFR, but that is a part and parcel of the medication, because initially it does reduce, but normally it will not cause any adverse reaction if you properly hydrate the patients. After some time, it becomes normal. And now SGLT2 inhibitors have been shown to improve the CV risk factor. So we have discussed this multiple times, but anyway, so if you, this is not a direct head-to-head comparison, but the effect of, effect of SGLT2 inhibitor on the SB1C, weight reduction, systolic blood pressure. If you see all the medications like also SGLT2 inhibitor, including empagliflozin, canagliflozin, or even dapagliflozin, does have an effect. But if you look at the magnitude of the effect, when you talk of the glycohemoglobin reduction, it is the highest among all other comparator molecules. And when you talk of the systolic blood pressure, this is the highest reduction in the blood pressure. It has been observed with the dapagliflozin, not with the other medications. So now all of you know, once you have a type 2 diabetes or diabetes with the early CKD or even with the advanced CKD, or if you have a diabetes, the patient's life span reduces significantly. Say, for instance, if you have a diabetes itself brings down your life expectancy by 5.7 years on an average. If you have a diabetes with the early disease at the time of onset, your lifespan reduces by 9.1 years. And if you have a diabetes with the MI or even a stroke, you have a significant reduction in the lifespan by 11.2 years on an average. So another problem with the diabetic patients, diabetic patients, they have a subtle heart failure, like a subclinical heart failure, which is not, clinically detectable, especially even if you use echocardiography as a routine method. Even there you can get a normal, preserved ejection fraction, but still a patient can have a heart failure. Only way to detect that one is to do NT-proBNP, which will tell you the patient's status. So heart failure is a very common condition, and then it can cause, it can lead to the hospitalization. And if it is it may be a single hospitalization, multiple hospitalization. This hospitalization and then the re-hospitalization has become a very important judging parameter for the drug's efficacy. Like if you can reduce the multiple hospitalization or re-hospitalization, you'll be saving a life, because re-hospitalization in a patients with a diabetes, with a heart failure, is a very big risk factor for the reduction in the lifespan. Now, we'll talk about this trial, DAPA heart failure. All of you know about the trial, but we will just quickly go through this. They had about 4,744 patients in 20 countries, including Asian countries as well as the other countries. And they had the patients with the NYHA class 2 to 4, left ventricular ejection fraction was less than 40, NT-proBNP was more than 600. That means they were in some kind of a failure. And they excluded the patient if you have a eGFR of less than 30 milliliter and then systolic blood pressure less than 95 millimeter of mercury, and of course in type 1 diabetes. So they divided the patient into two groups. One was having a 2,371 patients, the other one 2,373 patients. Okay, so one group was assigned with the placebo, other one with the Dapagliflozin, along with the other medications, whatever the patients were taking is standard of care. Okay, so they had to visit the research center, visit 1, 2, 3, 4, like that, 4, 5, 6 visits there. Approximately this 6 visit, after 6 visit, they were called every 120 days. And then the primary, endpoint of this composite of the primary endpoint of this trial was CV death, hospitalization for the heart failure, urgent heart failure hospitalization. These are the few things. And then the background. Now, what we know is a SGLT2 co-transporter, the SGLT2 inhibitor, prevent the development of heart failure in patients with type 2 diabetes. And now the question comes, can they be used to treat patients with established heart failure? Yes, of course, we can do that. The benefit of SGLT2 inhibitors may be glucose independent. Okay, so the benefit of SGLT2 is a glucose independent. As I'm telling you, it's independent of the insulin action as well. So can SGLT2 inhibitor be used to treat patients without type 2? So if it's a glucose independent mechanism, so why not treat the patients without diabetes who are suffering from heart failure? Okay, so we are going to show some of the data related to this particular point. And they tested the SGLT2 inhibitor Dapagliflozin 10 milligram once daily, which were added to the standard therapy in patients with heart failure, and reduces heart failure with the reduced ejection fraction, and with or without diabetes. So what was the result? So these are the key baseline characteristics. The important point is, like, if you look at the age, they're in a middle age group. Okay. Both diabetic and non-diabetic, they are about 66, 67. That was the mean age. And then very well distributed, like other parameters, whether it's a ischemic etiology, very well, distribute. And also they took the patients who had the eGFR less than 60, but more than 30 ml. Okay. The number of the patients were 46 in the diabetic group and 36 in the non-diabetic group. Okay. So some of the patients had the history of prior heart failure. That also has been very comparatively, very evenly matched among the diabetic and non-diabetic patients. So the baseline treatment, all of we know, like either they are taking the S inhibitor, ARB or ARNI-based therapy, or only S inhibitor with the other drugs like beta blockers, or some of them are taking the ARNI-based therapy. These are the breakup of the patient. We'll not go into the details. But what the result was showing was like a CV death, hospitalization for heart failure, and urgent heart failure visit was much better with the Dapagliflozin group as compared with the placebo. That is a cumulative percentage of the event. And that is with the diabetes, and even with the non-diabetes, even the patients who didn't have diabetes, dapagliflozin, reduce the this primary endpoint composite, that is CV, death, heart failure for hospitalization, or the urgent heart failure hospitalization visit. And components of primary outcome, again, the in terms of cardiovascular death, again, dapagliflozin was superior to the placebo. That means it is not only safe, but also it's superior to placebo as compared with the placebo. Whereas if you have no diabetes, the effect was slightly less, but still it is visible. And again, in the components of primary outcome, we were looking at the worsening of the heart failure. It was again, whether patient had or didn't have a diabetes didn't matter. Dapagliflozin significantly reduced the worsening of the heart failure events. And whether there was any clinical meaningful changes, this is the cancers, this cardiomyopathy score. The brick red is for the placebo, and then the dapagliflozin that were compared. So whether it was deterioration after taking the medications, no. Okay, so it was as compared with the placebo. If you look at this dapagliflozin arm, this is the blue arm on the left side of the table, there was an improvement as compared with the placebo. And even if the patient didn't have a diabetes, again, they were showing some, this heart failure in this KCCQ scoring system. That means whether patient have a heart failure, have a diabetes or no diabetes, it did not matter in terms of, improvement in the KCCQ score. So, and this is to show the worsening of renal function endpoint. So what did it do to the renal function? Okay, so patient, whether had a diabetic or non-diabetic, this is with the placebo, this is with the dapagliflozin. So there was a significant reduction with the dapagliflozin. The hazard ratio was, 0.73 in terms of patients with the diabetes, and 0.67 significant reduction. Although it crosses the midline, but still there was some effect were observed. So now if you look at this forest chart, all this this square falls on the left side of the midline. That means it favors the use of dapagliflozin whenever you talk of the patients, whether they had a diabetes or no diabetes, and also the different tertiles of hemoglobin. If you have a hemoglobin, whether it's a 5.6 or less, or it's 5.7 or more, up to 5.9, or even more than 6, all of them were benefited when they they were added with the dapagliflozin. So this is to show the NT-pro, the NT-pro BNP from the baseline. NT-pro BNP, all of you know that increases in the heart failure. So there was a significant improvement. Okay, in fact, there was a 303, a picogram per ml of this improvement. I mean, reduction in the NT-pro BNP, meaning that patient had a significant improvement in terms of heart failure. So just to summarize and conclusion of this particular set of the things, we are going to come for more slides. When added to the standard therapy, DAPA reduced the risk of worsening of heart failure events and cardiovascular death, and improved the symptoms in patients with heart failure with reduced ejection fraction, both with or without diabetes. This is one important point to note. And then the relative and absolute risk reduction in death and hospitalization were substantial, clinically important, and consistent in patients with or without type 2 diabetes. It was also well tolerated, and the rate of treatment discontinuation was low in patients with or without type 2 diabetes. DAPA also offers a new approach to the treatment of heart failure with reduced ejection fraction with or without diabetes. So this is the very important point to note, that this is one of the reasons some people even went on to say that it may be indicated for the heart failure even without diabetes. So this is the food and drug indications for use of the Dapagliflozin. And the DAPA heart failure results are rigorous, and also it's a practice changing and paradigm shifting, because this result was so significant because it was a large trial. It was a multicentric and multi-country, and it has a very good persuasive p-value, and it was internally consistent in all subgroups. It was a large effect size, and it had a significant mortality reduction. There's a marked improvement in quality of life on top of excellent background therapy. It was found to be safe, and similar benefits in patients with or without diabetes. So SGLT2 inhibition is a new pillar for the heart failure with reduced ejection fraction. Look at the medications, other medications so far we've been using for last 25 years, 25 years. S inhibitors, ARB-based therapy, along with the beta blockers, and then the mineralocorticoid receptor antagonist. And nowadays, like after 2014 and 15, we are using now ARNI along with the ARB, not with the S inhibitor, but ARB and other standard therapy. And now look at Dapagliflozin. It has also occupied the place one. In fact, it's a class one recommendation nowadays in terms of heart failure when we talk of the medications like Dapagliflozin. So again, we'll talk about the declared TIMI58. We'll quickly go through the things. The background of the declared TIMI trial was like that. Patients with the type 2 diabetes mellitus are high risk for the development of complications from atherosclerotic CV events and heart failure. Okay. And the DAPA is a selective SGLT2 inhibitor which blocks glucose and sodium resorption in the kidney, and thereby reduces the blood sugar. We have already talked about that. This is to say the same thing. Some safety questions with SGLT2 in other trials have been raised related to amputation, stroke, and decay. That's what we are going to see now. So this is the trial design. They had about 17,160 patients. We will not go into the details, but all of you are very familiar with this. But they had the two main arms. One was receiving DAPA 10 mg per day, and another was receiving placebo along with the other standard therapy. So they were followed up in person 6 months, and then some of them had a telephonic, like a questionnaire after 3 months of this thing. So primary endpoint was, like a CBD, MI, ischemic stroke, and then also the dual efficacy of CBD, heart hospitalization for the heart failure, and then the MACE. And these are the enrollment criteria. Again, here, the patients were sick patients, the patients with the ischemic heart disease, cerebrovascular disease, and also peripheral disease, or multiple risk factors for atherosclerotic cardiovascular disease. In fact, this trial had taken a lot of sick patients for the things. And then, of course, the man above 55 years and women more than 60 years with at least one additional risk factor. This also, this consists of the significant atherosclerotic cardiovascular disease. Okay, so for them, like what we are looking was like it was looking for the primary prevention. So this patient had a dyslipidemia, hypertension, and then the some of them were diabetic, and then also taking the medications for other reasons. And these are the baseline characteristics. Not much to talk about, except the age was similar as with the DAPA heart failure trial, and all other things were properly matched. And then, of course, like it was a multi-centric, multi-country, in fact, continent, you can call it. And then the 41% of these patients had a established CVD and then history of heart failure in at least 10% of the patients. So these are the medications used, like a glucose-lowering medications like metformin, insulin, sulfonylurea, etc., with GLP-1 based therapy, and then also cardiovascular therapies like antiplatelet agents, S inhibitors, ARB, beta blockers, statin, and ezetimibe also. So they had all the sick patients were enrolled over here. So this is the result in terms of cardiovascular event and then hospitalization for the heart failure. There was a significant reduction as compared with the placebo. This red one with the placebo, the blue one with the patients who are taking the Dapagliflozin along with the other standard therapy for the diabetes and the heart failure. So MACE, in terms of like a cardiovascular death, it was comparable with the placebo. So what it means is like it is comparable with the placebo in terms of safety, and also like it was better in terms of efficacy when we talk of the renal composite. Also here, hospitalization for the heart failure and CVD, and even the similar results shows in the renal composite. That also it was better as compared with the placebo. But when you talk of the all-cause mortality, it was not inferior to placebo. What this slide means to that. And other endpoint components, say for instance, hospitalization for the heart failure, myocardial infarction, ischemic stroke, CV death, non-CV death, and also deterioration of the when you talk of the deterioration of the eGFR, all of them favors the use of Dapagliflozin. If you use Dapagliflozin, all these parameters can be reduced significantly. And these are the key safety factors. What are the things? The main important adverse reactions which were observed with the Dapagliflozin was one of them is urinary tract infection, and some of the decay has been reported, especially in those patients who are in a very high dose of insulin. Thin patients, they are very much prone to go into the decay, like if you don't use the drug judiciously, and then if you fail to monitor properly. And of course, genital infection, that's a class effect. It happens with all the SGLT2 inhibitor, but here it was found to be significant. These are the few adverse effects. Rest of the key safety, safety features were quite acceptable. So to summarize this, in DECLARE TIMI58, the largest SGLT2 inhibitor trial, which included a broad representation of primary and the secondary prevention in patients. DAPA reduced the CVD, hospitalization for the heart failure, and neither increased nor decreased the MACE. So that means it was not non-inferior to placebo. And DAPA was safe and generally well tolerated in terms of well tolerated. But when in terms of genital infection, they showed some more increase, and also decay, which I've we have discussed. And there's no difference in amputation, stroke, or fracture, and there was a reduced incidence of the hypoglycemia. To conclude, now with the context of 3 large CVOTs, SGLT2 inhibitors have moderate benefit on atherosclerotic MACE that appear confined to those with established atherosclerotic cardiovascular disease. SGLT2 inhibitors have a robust effect on reducing the risk of heart failure and renal outcome, which do not appear dependent on baseline atherosclerotic risk, prior heart failure, or renal function. These data with DAPA from DECLARE TIMI58 extend the benefit of SGLT2 to a broader population of patients of primary or secondary prevention. So we talked about the design of the trial. It can be used as a primary prevention as well as the secondary prevention. So where we are in 2021, okay, so we'll quickly go through it. Moving forward from the neurohumoral modulation, a new era, like when we talk of the treating the hypertension and then the heart failure, we talk about the digitalis glycosides used long time back, like a digoxin, digitoxin, etc. And later on, we supplemented with the diuretics and neurohumoral blocker like S inhibitor, ARB, or MRA. And now the latest one we have is a neprilysin inhibitor like sacubitril, which is combined with the ARBs to treat the heart failure effectively. So these are the new treatment. Now on top of that, if you see other parameters but the problem with this, despite all the guidelines, patients still have a significant amount of heart failure, and then the patient fails to, in fact, it's a patient's failure as well as the clinician's inertia, these patients with the heart failure almost always treated 85%. In fact, it is reported 85% of the patients with the heart failure are treated inadequately. So this is what this slide is showing, whether it is ACE inhibitor, ARB-based therapy, ARNI, or any beta blocker or MRA. Okay, so on top of that, like if you add Dapagliflozin, that might improve the outcome, because despite all the medications, patients still were having a significant risk for the death. So this is to show the class 1 therapy indication. This is the algorithm showing the, like a management of patients with the heart failure with the reduced ejection fraction. We'll not go into the details, but all of you know how to categorize this patient, whether patient has a LV ejection fraction more than 35 or less than 35. All these patients were given the standard therapy. All of us know. If the only things to note is if the symptom persists, we have to, consider the patients, with the class 2 type of drugs, like class 2 drugs, like say, for instance, diuretic up to the maximum dose, etc. Okay, so 2021 update to the 2017 ACC expert consensus decision pathway for the optimization of the heart failure treatment answers to 10 pivotal issues about heart failure with reduced ejection fraction. So this is again to show the algorithm. If you have a patient like with the hospitalization with the heart failure, or the where you need a further class of treatment which is not been classified as a class 1, there also you can use this other medications, including Dapagliflozin. And now, but recently, after this big trial, Dapagliflozin or empagliflozin are recommended for patients with hospitalization for the heart failure to reduce the risk of heart failure hospitalization with the death. As a new recommendation is, this is class 1A, okay, class 1 level A recommendation. So of all the drugs, of all the other drugs which has been used for so many years, now it has come in a very first place with the class 1A recommendation. That also we have to remember whenever we are talking of treating the patients with heart failure. And then all of you know, patients with the heart failure, type 2 diabetes and with the hypertension, they have a very high incidence of heart failure. Sometimes even the subtle heart failure, which is not detected clinically, we have to do the special test to find out early and then treat early aggressively. And these are the now new pillars of the diabetes, new pillars of the treatment of heart failure with the reduced ejection fraction. Okay, so you do the RAS inhibition or the ARNI-based therapy or beta blockers, mineralocorticoid, receptor antagonist, SGLT2 inhibitor, and loop diuretics. These are all class 1A, either 1B, 1A, 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 and then loop diuretics are class 1C, a recommendation. And now, SGLT2 inhibitors in chronic kidney disease and role of Dapagliflozin has been well defined now. So, DAPA-CKD trial. This is again another trial to show the improvement in the kidney failure. We'll not go into the details of the trial because of the lack of time. But the objective of the trial was to assess whether the treatment with Dapagliflozin compared with the placebo reduced the risk of renal and CV events in patients with CKD with or without type 2 diabetes, and who are receiving standard of care, including a maximum tolerated dose of ACE inhibitor or ARB. So primary outcome was to see the composite outcome of sustained more than 50% eGFR decline, end-stage kidney disease, renal or CV death. And secondary outcome, that is in hierarchical order, was to see composite outcome of sustained more than 50% eGFR decline, end-stage renal disease or renal death, CV death or hospitalization for the heart failure, and of course the all-cause mortality. So this is the design of the trial. We'll not go into the details, but it was studied for almost 3 years. After a regular review meeting, the independent DMC recommended on 26th March that the trial to be stopped due to overwhelming efficacy. So look at this beautiful result, okay? Because of the overwhelming efficacy based on 408 primary endpoint events, 60% of planned events, the trial was prematurely stopped because it was found to be very, very effective. Okay, so it was unethical to continue with the trial and then they put the patient into the risk, those who were not taking the Dapagliflozin. So this is to show the result in the tabular form. This is with the DAPA, and then this is with the placebo. There are 39% relative risk reduction. Okay, and the number NNT was 19. That means you treat every 19% to get one benefit, which was significantly, I mean, statistically very significant, like a finding. So the like a dictum is an ounce of prevention is worth a pound of cure. Okay, so prevention is better. So earlier the treatment, aggressive the treatment, and better the outcome. All of you know, both in terms of kidney as well as the heart failure patients with or without diabetes. With this, I would like to conclude my talk, and thank you very much. If there's any question, I'm ready for it.
Sir, thank you so much for such an enlightening talk. Sir, we'll be taking questions, right? I've got a couple of questions that we can discuss.
Yeah.
Yeah, sir. So one question, I think the first question that has come in, doctor wants to know, how do you use an SGLT2 inhibitor when the patient is already on insulin? I think that is one question that we have got regarding insulin usage, and you want to use it with a SGLT2 inhibitor. So how do you try?
Yeah, I think I briefly mentioned there, the main mantra over here is to monitor the patient frequently. And if it is using for the first time, it is better to give insulin in a slightly reduced dose and monitor the patient closely. Because it has been found patients taking sulfonylurea and then the insulin, if you add SGLT2 inhibitor, they might go into, hypoglycemia. That is one of the risk factor. It is not because of Dapagliflozin, but adding Dapagliflozin does some kind of a magic, it brings down the sugar very fast. That is one of the reasons. Actually, one of the slide was showing if the metformin and sulfonylurea fails, you add the Dapagliflozin and suddenly reduces the blood sugar significantly. There's some additive effect. Thank you.
Right, sir. Sir, another question is regarding the use in heart failure. Like, how do you, initiate with a diuretic dose? So I think a diuretic plus an SGLT2 inhibitor, do you feel there is a need to reduce the dose? Or
normally, heart failure has to be first categorized, which stage, whether patient has a advanced heart failure or early stage heart failure. If it is early stage heart failure, sometimes the diuretics may not be needed. But if you have a very early stage heart failure, and then the patient is on medication, not only for the heart failure, also for the diabetes, then it has a two-way effect. You are treating hyperglycemia as well as you are treating the heart failure. That becomes a bone in disguise, okay? But if you have an advanced heart failure patients already taking diuretic, then one thing is to remember is the SGLT2 inhibitor is working not as a diuretic. Remember this one, okay? It's independent of diuretic effect of the this thing. It has some other effect that causes the heart failure. In fact, further research needed, because one of them we have not mentioned today is it has a modulatory effect on the cardiac muscles. Okay, so as a result, you get the favorable result, and then there is a some kind of a cardiac muscle regeneration leading to the better, ejection fraction. That is one. So when the patient is taking a maximum dose of diuretic, we must ensure that patients should take the adequate amount of the fluid, because sometimes the patient is in a like a edematous patient, their volume overload. There you are supposed to reduce the fluid. But if your patient is not that bad, then when you are using this SGLT2 inhibitor, then you should ensure adequate amount of fluid intake. Adequate means like at least you should maintain the minimum urinary volume.
Right, sir. Right. So one last question. I think it's a very direct question, but I'll just try to frame it in a different way. So how do you choose between an SGLT2 inhibitor? Like we have three available, one even remogliflozin is available. How do you decide which patient gets which SGLT2 inhibitor? where CANA, where DAPA, and where EMPA. I think that is.
Yeah. Number one, whenever you consider any drug of the same class, first of all, is like we see. What I do is I see the like a class effect. What are the class effect and what is the difference? Okay. And now when you talk of the larger trial and when you talk of the things, they are comparable, but there's some shortcomings. Say, for instance, canagliflozin, there's still some, like a concern about the amputations, as well as in terms of blood pressure reduction, DAPA was doing better. And in terms of glycohemoglobin reducing, DAPA was doing better. In terms of kidney outcome, again, it was doing better. So that way, my opinion tilts towards the DAPA. But again, I will see another important point, that is the affordability.
Right.
Okay. Now, it was not affordable till few months back, but now it has been affordable. Then why not pick up the SGLT2 inhibitor this Dapagliflozin? Because now that scores over all. Because whether you look at the economy, whether you look at the mode of action, whether you look at the advantages of medications as compared with one, obviously I'll pick up the Dapagliflozin now.
Right. Thank you so much, sir, for such an enlightening session. We really appreciate you taking out time from a busy schedule and addressing the audience. We had, sir, more than 50 doctors attending this seminar. So I think they really felt, they really enjoyed the session. And thank you so much on behalf of Curious Mankind Specialties. So just to add, we also have a Dapagliflozin by the name of Justoza. So hoping that, sir, that everybody, who's listening to us would consider Justoza, considering it's an DMF grade API. Thank you so much, sir, for your time.
Thank you once again. Thank you. Good night, all of you.
Good night. Thank you so much.
Good night.